without further ado, come on up, Chad.
Thank you so much. I really appreciate everybody coming out. I know it takes a motivated group to come out on a beautiful August day to sit through an insurance lecture, essentially, and how to pay for primary care services. But it also kind of illustrates where we are, that's worth your time. Just a quick kudos to my precursor. We owe the innovation in the free market system within the state of Michigan to Senator Colbeck. I know that sounds dramatic to attribute it all to one person, but prior to his passage of SB 1033, I believe it was, and actually was signed into law in January, I believe, of 2015, we couldn't do any innovation because to do a different model was considered illegal. They considered us an insurance plan. So we got out of that regulatory burden, and his law allowed us to say, no, it's just an innovative way of paying for primary care services and get to know them. But anyway, so going back to our topic, again, appreciate the St. Joe docs inviting me out. So with direct primary care, the first question is, well, what's wrong with the current system, right? What's wrong with it? Well, in the current insurance-based system of care, where the doctor is compensated by the insurance company, physicians are massively overworked. Now, a lot of people say, well, what's the big deal about that? They make a lot of money, you should work really hard. Well, the problem is if you get an uncaring, uncompassionate doctor, you probably have a burned out doctor. That is not good for the doctor, but it's also not good for patient care. So what that results in is extremely long waits for care. Each year, this number ticks up. Last year, I used to tell people the national average for seeing a doctor, primary care doctor, was 19.5 days. Well, that is now 24 days. Each year, as doctors become progressively more and more overburdened, the wait times to see them extend. Now, this is really bad if you're sick and you can't get in to see your doctor, and what it causes is a diversion to less cost-effective locations to access your care, meaning emergency departments, urgent cares, places like that. When you have a problem like a cold, which could easily be handled in your primary care office, in fact, should be handled in your primary care office. Sadly, after all that wait time, you get the opportunity to wait some more. They've shown that the average person has to dedicate over 3 hours to each visit to their primary care doctor. Drive time in, waiting in the waiting room, brought back, waiting in the exam room, doctor comes in and out, waiting in the exam room for the people to be checked out, drive time home, over 3 hours. And that time is valuable. That is your time that you could be at work, with your family, or doing whatever it is that you want to do with your time. I'm sure you have a lot better things to do than sit in our waiting rooms. And in fact, they've estimated that in the United States, we waste $52 billion with a B every year in opportunity cost, the value of your time wasted waiting in doctors' offices. And after all that waiting, you're graced with short, quick visits, right? Come in, come out, oh, I've been waiting, oh good, 3 weeks waiting to see my doctor, and hi, how you doing? Oh, okay, bye-bye. What was that? 8 minutes, 8 to 10 minutes average visit times. And unfortunately, it's actually worse than that, because that doctor is distracted. It's not even a quality 8 to 10 minutes. They many times have their back to staring at the computer, typing away, because that's how they get paid. Not knocking them. I was one of them. I was an insurance-based doctor too. That you have to do that to stay in business. But that's not focused on the patient. It's focused on the bill and the insurance payment mechanism. And they've actually shown that doctors spend twice as much time involved in documentation activities than meaningfully interacting with their patients. And sadly, it gets worse than that, because there are also conflicts of interest intentionally injected into the system. Now, what do I mean by that? There are, under these value-based metric systems that they're paying doctors, there are situations where the doctor can be paid more to deny you care. And I use the classic example of ordering an MRI. So imagine you blow your knee out and it really hurts. And you think you blew your ACL. Everybody knows, watch football and sports, and what that type of injury is. Well, you need an MRI. Well, that doctor is harmed financially. Their reimbursement can be decreased if they order too many MRIs. Your doctor should never be at that conflict of interest with you. They can get dinged, even if it's 100% the right thing to do for you. And I've never seen a graph that more succinctly describes what's happened in our healthcare system than this one. So let me just explain this really quick. So this is a graph that looks at a 4-decade period of time from 1970 to approximately 2010. This brown line down here is the supply of doctors in the United States. And as you can see, it's relatively stable over that period of time. The yellow is the number of administrators in the healthcare system. And as you can see, there has been a veritable explosion of administrative, i.e. bureaucratic costs that have been injected into the system. And this black line, this is the per capita spending, what you and I, everybody spends on medical care every year. And as you can tell, it's much more closely following the trend line of the increasing bureaucratic burden than it is the supply of physicians. And it's so bad that by 2010, according to the US Department of Labor and Statistics, there were 4.5 million Americans whose job title was healthcare administrator, actively managing about 700,000 to 800,000 doctors who are actively practicing. So, and this is what it feels like, sadly. The 800-pound gorilla of the third-party payer system meaning insurance companies and governmental payment systems, that accompanies that doctor into each exam room with each patient every day. And since he carries the piggy bank, with it, like a marionette, they're able to control the physician, tell them how many patients they gotta see, what questions they can ask, and even dictate the treatment plans. And if you've ever had to do a prior authorization, you doubt that? That's an example of dictating treatment plans. Now, I wouldn't bring up a problem unless I thought there was a solution, and part of that solution is something called direct primary care, which the St. Joe doctors are converting to. In direct primary care, it's a low-cost monthly membership where the doctor works directly for the patient. We get rid of all that yellow, right? It's a direct relationship. You're getting all the middlemen out of the way as much as possible. Because of that, there are no billing hassles. These bill out just like a gym membership. It classically goes to a credit card set up with the same kind of software, goes to a credit card every month, easy, just no-brainer, just, very simplistic, and it gets rid of all the conflicts of interest because that doctor is now your advocate. They work for you. They're not actually working for someone else. It's a wrap price, so it's nice and predictable. You know what your costs are every month of your primary care services at this practice. You don't get what I like to call the gotcha bill. You go into an ER or you're ever hospitalized or anything, anybody who's ever done that knows what I'm talking about. 3-4 weeks later, you have no idea what things cost. 3-4 weeks later, you get something in the mailbox, kind of look at, oh good, oh my gosh, this is ridiculous. What happens 2-3 days later? You get another one. You get a different one for all these different people. You got all these, various, that's for the doctor, that's for the ER, that's for radiology, that's for labs. You get this trickle of gotcha bills and they're all outrageous. We have massively improved accessibility in these kind of practices. And the reason why is we have much more restricted patient base. Most primary care doctors in the direct primary care field are like 600-700 patients. Almost all limit their practices to less than 1,000. And what that means is when you are sick, you're not waiting 24 days to get in. That's not good care. You're getting in same or next day. And when you get there, because they have reasonable patient loads, by the way, less than 1,000 is essentially the historic norm. Doctors nowadays, again, 2,500, 3,000, 4,000 patients or more. That's not uncommon for primary care doctors. About 1,000 was the norm before 1980 for a doctor to have. So this is the historic anomaly, what we're experiencing today. So we're trying to go back to more traditional historic norms for doctor-patient loads. And with that, that means we can spend more time with them. So not only can you get in conveniently and quickly, but your doctor is relaxed, comes in, you can talk about multiple topics. Doctors many times have to talk about one because of the way the billing structures are set up. Oh, you want a second thing? I don't have time for that. You've got to come back tomorrow, make another appointment. Well, there's your opportunity cost. Now you're dedicating another 3 hours. So visits are usually scheduled in 30-minute and 1-hour increments. So you have plenty of time to go through the issues that concern you. And it's patient-centered. It's focused on you. There's something in healthcare policy circles they call patient-centered medical home. Well, if you guys know what that is, and if you've ever looked at one of those contracts, these are payment-centered medical homes. After you get past the title, all of it's about the payment. The doctor gets an extra percentage here or percentage there based on if they adhere to what the insurance company is instructing them to do. And it allows for innovative delivery systems. By getting away from the antiquated billing and coding processes of the United States, which is called CPT, we can create new and innovative ways to access your doctor, and I'll come back to that in a second. So what does a membership model of medical care look like? Well, it includes all your office visits. No co-pays, as much as you need. You're in 1 week for a physical, you can come back the next week for a sick visit, and you're not going to get charged anymore. Now this is really, really important. Multiple studies have now shown that if you increase the cost of a visit or the co-payment of a visit, people use it less. Well, that makes sense kind of in a roundabout way, thinking, well, you're going to decrease primary care services, so that will decrease cost of the system, but it's wrong. It's a wrong assumption. Because what they found is when you decrease the primary care utilization, you double those savings in new costs of hospitalization. And what that means is that person who initially would have come in with an illness, early, easier to treat, delays access to care so much that they're sicker and they end up in the hospital. Now that has a financial toll, but that also has a massive human toll. That means people are sick. They're getting sicker. Some are even dying because they're delaying utilization of doctors. Well, in this model, you're not disincentivized to use your doctor. You have already compensated for their care in the membership, so you are not dissuaded from using them appropriately. To make it convenient, we also include all in-office diagnostics, EKG, spirometries, pulse oximetry, whatever it is that doctor would normally do in the context of their practice. We wrap that in within the rack price. So if they want to do an EKG on you, you don't have to be like, oh wait, that's going to be an extra $50. No. We think it's necessary. It really is not expensive for us to do. It's our time, which you've already compensated in the model, some paper, some stickers. I mean, it's not expensive. We just include those within the membership. It also includes all in-office procedures. So if you're doing a skin biopsy, you may have to send it out for pathology. That could be more. I don't know if you guys are wrapping that in or not. Usually it's going to be a little more. But if you do the pathology, you do the biopsy. We do joint injections. We do cryotherapy, wart removal, ear lavage, these kind of things. We don't charge more. You have to nickel and dime people in the insurance model. You have to put a code on for everything, including your analyses, which cost about 10 to 15 cents to actually do. So the time that it takes to bill it, document it, and code it is far more than just simply doing it. In our model, we can do that. And we also do something I think is incredibly innovative. I call them virtual home visits because I think that better describes what it is. It's more colloquially known as telemedicine. And this means using the advancements of technology to access your doctor remotely. So emails, text messages, Skype, whatever it is, you can now use that to avoid that 3-hour office visit time dedication to call your doctor, email or text. And even though some practices are trying to incorporate that, in reality, the current insurance-based practices are essentially only compensated by you being in the office. So even if you did go to their portal and send them an email, they're never really incentivized to resolve your situation. They're incentivized to drive more office visits. Oh, that's too bad. Come on in and see us. Then we can bill for it, which I understand. It's rational from the way they're set up. Ours, no, you paid us for our services, whether you're in the office or on the phone or through a text message, as long as it's medically appropriate. That's great. We can do whatever it is that makes care convenient for you. This is revolutionary. Let me give you an example of that. So imagine it's a Saturday morning and you just got done working in your garden and you think, oh God, I got this itchy, you wake up, you got this itchy rash. You think, oh, I was out there, I saw that poison ivy, but I thought I stayed away from it. Oh, this is terrible. This is driving me nuts. I'll call my doctor. Maybe I can get in on Monday, my insurance doctor, and maybe they'll be able to treat this. Oh wait, it takes like 24 days to get in. I'll be lucky if I get in even this week. Oh, I can't take this anymore. I'm just going to the ER. Under our model, you forget about that. You pull out your cell phone, high definition camera, you take a picture of it, text it to us. Hey doc, got an itchy rash in the garden yesterday. I think it could be poison ivy. We text back. Why? That does look like poison ivy. Let me call some triamcinolone ointment in for you. Let me know if you don't feel better. Quick, easy, convenient, cost-effective, great access to care, prevents the expensive ER urgent care evaluation, and it's good not only for the patient, it's good for the doctor, and it's good care. You got a history in the garden, itchy rash, you got a physical, you got a high-definition picture, which is, by the way, usually incorporated into the electronic record system. You got a treatment plan, try some triamcinolone ointment, and you got a follow-up. Let me know if you don't feel better. It's actually good care, and it's really good for a third person that I didn't mention. And that's the really sick person who was going to come in on Monday. But their visit, and they just got discharged from the hospital from heart failure or something dramatic. But they were going to get that 8-minute visit because that doctor has to rush through that practice and get to that poison ivy case that could have been easily handled on the phone on Saturday in a matter of minutes. So now that doctor is allowed to spend more time and focus on that sick person, give them better care, and the type of care they need, hopefully prevent them having a worse health outcome. So to make this as cost effective as possible, direct primary care doctors have linked this with significantly discounted laboratory prices and medications through in-office pharmacies. It is legal in the state of Michigan with an additional license, which we all have, to dispense directly to our patients only. We are not general pharmacies. So let me give you some example of these prices. So labs, if anybody's ever gotten a lab bill, bring it up, pull up, if they got a video going here, pull it up, look at these prices. This is right from their website. So a CPC, anybody know what that is? You got it? Okay, good. What is it?
I just have to get one every month.
Oh! Do you pay $2 every month? Yeah. So check your bill, see what it is. Those bill frequently $50 to $85, anywhere in that range. So that's your white count, which are your immune cells, can sometimes implicate certain cancers and things of that sort, infections. Hemoglobin, hematocrit, looks for anemia. Platelets, which is your clotting cells. A lot of information we derive from that. Cell size can suggest things like B12 deficiency, iron deficiency, other things. $2. $2. They do something called a direct area client services billing. They have a contract with a national lab. They give them the same prices they give the hospitals. This is what it actually costs to do it. They don't do an upcharge, they give it to you. You get the actual price. This has been very illuminating when I started doing direct primary care. I had no idea the degree of markup that's in the medical services industry. You're talking 1,000, 2,000 or more % for most things. Thyroid, $4. Cholesterol panel, $5. The comprehensive metabolic panel, that's kidney function, liver function, salt level, sugar level, a lot of information there, $4.50. Now, as you guys know, when doctors order tests, they don't just order one, they order multiple panels. So you're talking $50, $80, $100 savings on every one of those tests. It's not uncommon for physical exam panels to be billed at over $400. You could do it here for probably $20, $30 maybe. So that's a huge amount of savings. They also have the in-office pharmacy. Now these are extrapolations. I know they're actually prices maybe a little better than this. We use the same dispensary, and I was using my markup of 10%, which covers the cost of the pill bottle and the label. They said they're only marking it up by 2%. So they're more generous than I am. So just to give you an example, look at Zestrel here. This is a great blood pressure medication. It also works for heart failure and kidney damage. Really good drug. This treats blood pressure, right? One of the leading causes of preventable premature death, vascular disease. You can treat hypertension for an entire month for 24 cents. What does that mean? You can treat one of the leading causes of premature death for an entire month for less than the cost of a gumball. So what does all this got to cost, right? Monthly membership, unlimited primary care, as much as you need to see your doctor, new ways of accessing care, discount includes all in-office labs, meds, imaging, discounted meds, no conflicts of interest, etc., etc. That's got to be really expensive. Well, it's a lot better than you probably think. You can cover an entire family with unlimited primary care services through their practice for $150 a month. So what do you get for that, right? So you get same or next day acute visits. You get your annual physicals. You can get sports physicals. You can get chronic care like diabetic management, heart failure management. You get newborn and pediatric care. You can get your DOT physicals if you guys have trucking companies or anything. You can get group education like nutrition, counseling. You can get potential home visits. You can do spinal manipulation instead of the chiropractor. See these guys. You can get discounted meds. You can get splinting. You can get DME. You can get EKGs. You can get discounted lab costs. You can get, again, spirometry. You can get the skin biopsies. You can get cryotherapy, which is freezing and warts. You can get joint injections. You can get colposcopies, endometrial biopsy. You can get serum disinfection, tetanus shots. You can get flu shots. You can get point-of-care labs, including INR, urine pregnancy, hemoglobin, urinalysis, lead testing, the hemoglobin A1C microscopy. One more. I used to be a rapper in another life. Getting jiggy with it. And actually, I don't know if you guys noticed, they do lead testing. Lead testing, right? We could have used them in Flint. Right, Senator? Right. So that's a lot. So what does this break down to? So they also have discounts. I showed you their monthly rates, but if you ever look at their website, you'll see they also offer discounts. If you want to pay it all up front for the year, they give you a month free. So I thought, okay, if you did that and you divide it by 365, when you go to the daily rate, what is unlimited primary care and all of that stuff that I just almost passed out saying, what does that got to cost? Well, you can do an entire, I know, it's pretty dramatic, eh? I love my graphics. You should see me with emojis. So you can get unlimited primary care, unlimited, for $4.25 a day for your entire family, which makes me ask the question, how much was your coffee this morning? Basically, a cup of coffee for an entire family. So now I'd like to just quickly discuss too, specific advantages to businesses. So if you can actually contract directly with direct primary care practices if you're a business owner, and you can offer them as an extremely high value, inexpensive healthcare benefit. Now, not in place of insurance coverage, but with it. You can use this to keep them healthier and actually to help with recruitment. Say, if you got somebody out of state, you need to recruit somebody for a high-tech job or something of that sort, you say, listen, you can see your doctor much more, zero copays, no nothing, you can see them, you got telemedicine, 24-hour coverage, and it's inexpensive, high value, inexpensive. If you have a trucking component to your company, DOT physicals. Most people who have a trucking component pay more for a DOT physical. They have to do that separate. You get low rates of absenteeism, meaning by having better primary care and better care, you're keeping people out of the hospital. If they're not in the hospital, it's more likely they're on the job. You get included flu shots. They wrap this into the membership. This isn't more flu and tetanus shots. So HR departments have conducted studies to look at the value of flu shots, and they've actually shown that you as an employer should provide flu shots at no charge to your employees because they pay for themselves and decrease absenteeism. So, well, you have to do that separate under the current system. They wrap it in. They do that for free with the membership. It also allows for less costly coverage options, meaning if you are providing 80% of the medical care, unlimited primary care and all those discounted services, without harming, in fact, giving your employees better coverage, you can get less expensive coverage. You get same day or next day medical care. So again, decreasing absenteeism. They're sick, they get in quickly, get treated, hopefully back to the job quicker. And you get timely visits or telemedicine. Depending on the problem, we can't treat everything remotely, but depending on the problem, they may not even have to leave work. They could potentially access their doctor directly from the job. So real quickly, I'd like to just give a quick discussion on insurance coverage. Now, I am not an insurance expert. This is a disclaimer. I'm not a financial advisor. These are just general ideas, general observations about insurance coverage. Direct primary care works extremely well with high deductible PPO insurance products, and as I understand, that's primarily what you guys are using around here because of your proximity to Indiana. That's great. They work great for us. HMOs could create problems. We work really well with non-traditional health sharing options. These are things like MediShare, Liberty, Samaritan Health Ministries, and Christian Healthcare Ministries, which are ACA-compliant coverage options. And we also work extremely well with ERISA-based self-insurance products companies who self-insure for their employees. Really good, because we decrease the costs. So let me introduce you to my hypothetical family, the Johnson family. Fictional family, real quotes. So this is two parents in their early 50s and 3 kids essentially in their teens. So these are real quotes. I went out and got quotes on what would it cost. This is not including direct primary care. I just wanted to see what does the various coverage options cost. So this is just staggering to me. This is from ehealthinsurance.com. So red here is a premium. This is what you pay every month and over the course of the year, no matter whether you see a doctor or not. That is a check going out to the insurance company. You may or may not get anything in return for it. The gray here is your deductible. This is what you have to pay out of pocket before this red here kicks in and covers anything. This is before your insurance company covers anything. You have to hit the gray. You have to pay all of that before the red covers anything. And the brown is what's called maximum out of pocket. A lot of people are under the false idea that once I use my deductible, I pay nothing for my care. That's not true. Most of them have co-payments or co-insurance afterwards. These plans are 80/20s that I quoted here, meaning you still have to bear 20% of your falsely elevated bills, right? So 20% on a false number, what does that mean? It's not really a discount. It's a false number. You can't make that assumption. So you still have to pay 20% until you max this out, and then that's the maximum you pay. So I did just a little mind experiment, and I said, what if you have the worst medical year of your life? Somebody's hospitalized, multiple medical expenses. So this family of 5, they have to spend $32,000 every year, whether they see a doctor or not, if they get the gold plan, the PPO gold plan. They still have a $500 deductible that they have to pay before they start utilizing this, and they could pay almost an additional $10,000 on top of that in out-of-pocket expenses before it actually caps off and they don't pay anymore beyond that point. That means if you have a bad year, you can pay almost $45,000, that family. Now, if they're smart and they go down here and they get a bronze plan, they decrease their premium for about 14 grand. Now, people go, oh, but look at that high deductible there. That's really scary. They got about 14 grand in deductible that's now there. But the premium, the red went down by 14 grand. So essentially it's a wash. They don't have an out-of-pocket maximum here. This is one of the few examples of what, if you really do blow this entire deductible, they really do pick up everything after that point. So in the worst year of your life, you're back up here, which is essentially equivalent to the gold plan every year. So all you've done by getting the gold plan compared to the bronze plan is give yourself financially the worst year of your life medically every single year. I'm looking at these policies, and maybe our insurance company expert over here can give me a reason. I can see no reason to ever buy this policy if you pay it all out of pocket without a subsidy or it's buried in employment costs. If you actually buy these on your own, I can see no reason to ever get this plan. So why does direct primary care help this? Because they call this, you're at risk for $14,000. You may have to pay $14,000. I call this opportunity. You don't have to pay $14,000. Here you have to. So if you have a good doctor who's getting you good care at good prices, you are much less likely to use this. And the money you save compared to buying this more expensive policy is money in your pocket, which you can use for your premium next year, or buy a TV, or I don't know, you could buy a car with that. There's a lot of things you can do. And this is one of the best kept secrets in medical finance. This is just one example of something called health sharing. These are ACA compliant, Obamacare compliant, you do not get a penalty, coverage options. These are not good if you have a lot of pre-existing conditions. There are things that you guys need to, if you're interested in these, look into them. There are some situations where they're not the best scenario, but if you're a relatively healthy person, they are a wonderful possible coverage option. And they have a $1,500 deductible, which is, they're immediately about a third the cost of the bronze plan for the entire family, about $6 grand a year. And it's almost 10% of the deductible. They don't call it deductible, they don't call it premium. They're not technically insurance, so they use different terminology, but it's analogous. So how does this look like if you combine it with direct primary care services? So again, you're adding on unlimited primary care. So if you were to add so if the person's really smart, and I'm not buying this, I don't want to pay my doctor through my insurance company. I'm going to just pay him directly. And maybe I won't use a lot of this $14,000. But they can get unlimited primary care for $1,600 for their entire family for the entire year when you get the annual discount through the St. Joe's docs. And you add it on, so you're talking around $20,000 instead of $32,000. They are $32,000. I mean, they're $12,000 in the positive by switching to cheaper insurance coverage and adding in a direct primary care benefit. And if they're really lucky and they can do something like this, Liberty currently, now again, don't quote me on these, they change their policies, but they actually partially cover direct primary care services, about $80 a month for families, which means the effective annual rate for that family of 5, the entire primary care services after the assistance from Liberty is about $690 for the entire thing. So if you think about that, I looked at this little green line and I said, wow, by just changing how you finance a system, not changing the care you get. In fact, I'd argue this person is getting better care than this person because they're getting all those benefits we talked about before. By changing, how many green lines would it take to equate this line over here, this red line? Not up here, just the red line. You could see your doctors for your entire family unlimited for 38.5 years, almost 4 decades, unlimited primary care by changing your coverage product for only 1 year. And if you did that every year and you march that out over a decade, you'd have enough money with cash to buy a pretty nice house. That's the type of savings we're talking about, how much money we waste in our coverage products. Personal editorializing there. So I also want to say, okay, well, what is this on a daily cost? That's a lot of money. What if you broke this down to a per day cost? I think this really brings it into perspective. So if you get that gold plan and you have that bad year, and you go, what was my average cost on a daily basis? You spend $90 every day for this gold plan, whether you see a doctor that year ever or not. $90 every single day. And if you're really unlucky and you get multiple hospitalizations, your average daily cost of medical care over that year is $118 every single day. You could see a doctor every single day for an entire year, including holidays and weekends, for what this coverage product costs you on a daily basis on average. And if you change it over here, look at this. So what's the primary care cost on a daily basis? Unlimited primary care, $1.89 a day. $1.89. You see that little line there? See, it's kind of hard to see, so I blew it up here. You see that little tiny line? That is 80% of your medical care. $1.89 a day for that family under this kind of coverage scenario. And if you did it through more traditional, it's still only $4.52 a day. So, and then quickly I'll touch on ERISA. I'm not an expert on this, but the general concept of the self-insurance products is if you have a company, let's say you've got a decent-sized company of $1 million that you spend on premiums over the course of the year, the concept of this is you go to a self-funded model. You get out of all the current ACA, Obamacare regulatory burden. You can design an insurance product that's right for your employees. So what they do here is the company controls the money. So conceptually what you would do is you would put $600,000 of that $1 million you were going to pay in premium into a self-funded risk pool, meaning that they draw from that pool for your employees' medical costs. So if they get a surgery or they do something, that it pulls from that risk pool. In a really bad year where something terrible happens, multiple people are sick, it's hard to use $600,000, mainly if you're getting a crisis. So then you take about $300,000, you put that aside, you purchase what's called a stop-loss policy. This is essentially a catastrophic coverage for a business. It means that if they blew through the $600,000, they do get an insurance company that pops in and starts covering expenses beyond that point. And there's about a 10% cost of getting an administrator to run that kind of fee. But the advantage of this, mainly when combined with direct primary care services, is we try to give you a good value, right? We're trying to cut your costs. So the chance of using that entire $600,000 is less. So let's say hypothetically they spend $300,000 over the course of the year. That means $300,000 gets to come back to that company that you can use as stock dividend or pay in bonuses or contribute to your premiums for the next year, whatever it is. So again, the company controls it. You can custom tailor your coverage. You don't, ERISAs are not, they're exempt from some of the current regulatory burdens. You get the stop losses, the employer retains the savings, and if you want to learn more about how to set something up like that, www.kemptongroup.com has more information on that. There's a lot of companies that do that, but they've got a real nice website with an educational section describing how to do that. So what kind of an impact does cost savings have if we can decrease medical costs, decrease the cost employer? Now this is antiquated data. This is 2008, U.S. Department of Labor and Statistics. They basically said whatever you're paying in wages to your employee, you're paying on average in the United States 30% more than that in benefits costs, almost all of which are health care. So if you have somebody and they make $50,000 a year, you say, well, what do you make? Oh, I make $50,000 a year, but you guys don't see that. You guys see $65,000 because they're paying about $15,000 in benefits above and beyond that. So you don't think of them as costing you $50,000, you think of them as costing $65,000. So if you're able to decrease medical costs, you can give that person, in an era of stagnating wages, a 10% pay raise. What would that do for morale? And at the same time, you decrease your cost of employing them by about $5,000. So that means that labor costs are much less. You can produce goods and services at a much lower, more competitive rate here in the United States, which means we can become competitive globally. We're able to produce goods and services in the United States, export them. This would be not only a boon to your company, this would be a boon to our economy as a whole. And you've heard me talk a lot about dollars and cents. But their worth is more than just dollars and cents. What is it worth to know your doctor has your back? They work for you. Well, I would argue it's priceless. So to summarize, direct primary care. It's a low-cost membership model of medical care. It includes all your visits, all your in-office diagnostics, all your procedures. It includes telemedicine, discounted labs, discounted meds, discounted imaging, and no billing hassles. And best of yet all, no conflicts of interest. So the future with direct primary care, doctors being doctors, not being bureaucrats. So I really appreciate your attention. Thank you. Do you have one? It'll be a second Transition.
So we won't keep you guys very long, but my name is Mike Egerbrecht, and I'm one of the physicians at Family Physicians of St. Joseph, and I just want to give you a little history. So Family Physicians of St. Joe has been in existence for over 3 decades, something like that, at the Niles 2500 building, and we are moving from that building. We're actually building a new building at the corner of Hollywood Road and Peace Boulevard. So if you drive out there, you'll see our new building under construction. But the thing that really excites me is I've had the opportunity to practice with Dr. Prose and Dr. Heenan and then Dr. Shilio, and now all those guys have hence retired, and now I have 3 wonderful new partners. And I'm excited about the future of our practice. These guys are really innovative. I really enjoy working with them. And if I weren't signed up for direct primary care, I would after hearing you talk. So, that was actually very good, so very well done. But we have information on our website. For some reason, we're having AV problems, but our website information is in a brochure that you got. We're going to take some time now just to answer questions. So this was a very short presentation.
Anyone want to get started with a question?
Yeah, I have a question. We are, I'm the controller of Vail Rower, and we have an ERISA-based self-insured plan. So how can we directly pay, can the employer directly pay for the monthly fees of our employees? Or is that legal?
Well, sure, yeah. I actually have several companies. Can you hear me?
Yep.
I have several companies who contract directly with us, and they basically sign up all their employees. It's absolutely legal. We usually have separate contracts for those entities. Again, every company can do it a little different. Every practice can do it different. But our companies have an option that they can choose to cover the entirety of the membership or a percentage of the membership. They can cover all of labs, none of the labs, a percentage of the labs. So they have many options to custom tailor it. And basically they put a corporate card on file, they sign a contract, and everything's automatic after that. Very easy. They just have their employees sign up through our website. What EMR are you guys using?
Relation.
Okay, so it's probably a little different process, but same concept.
So from a legal standpoint, without specifically directing an employee to choose you, I mean, is there any legality issues to say, okay, there's 100 doctors in town, but I don't want to force my employees to go to you. I'd strongly encourage them to go to you because of the cost savings, but can I legally do that?
Yeah, I have to be careful about answering any legal questions because it's not my area of expertise. I will say my experience, I'll just preface it with that, is that there's no issues. However, I would encourage you not to force them from just a psychology of human beings aspect. We've dealt with that issue with some of our companies too, even though we provide a higher level of care. If you force people to do it, there's a natural inclination to be resistant. And there are some people who just love their doctor, had great relationships, in which case, hey, if they want to apply to their deductible and pay, that's fine. But you can put a great financial incentive to say, hey, listen, you direct primary care, we're covering that for you. Otherwise, you're doing your deductible and going to your old doctor, which is fine if it's up to you, but it's your choice. That's why my practice is called Your Choice. Usually at least what I've seen so far, is in the first year you get maybe about 30-40% of the people take them up. But then the next year almost everybody does. Because they go back and they go, man, that was good. Or they see them texting us in the middle of the day and they're like, what are you doing? I'm texting my doc. Oh, look at that, they just replied. What? No. It's so different that people have a hard time comprehending. And just a quick comment, when I first started, in 2015, I had a bunch of people sign up for my annual memberships. At the end of the first year, I had almost a 100% retention rate. So we won a lot of them over with the initial financial. And I understand finances motivate people, but that wouldn't have kept them there if they didn't think they were getting a value. So that to me was the best compliment we ever had. They voted for us with their dollars that we were doing a good job.
There are many companies that go off and have direct primary care contracts work with their employees. Some of them actually have on-site direct primary care physicians. So I mean, they say we'll cover it if you go to this guy, but we're not going to cover it if you go somewhere else. Right. So you make it very simple on it. It's all a function of your employee benefit program, and as long as you're managing expectations up front with your employees, you should be okay.
As I understand it, the cost of this cannot be reimbursed out of HSAs, but out of FSAs. Is that
Can I answer
where we're
that,
at?
too? Sorry, I don't mean to dominate this. The law is ambiguous because it's not actually law, it's IRS policy. So when HSAs were created, direct primary care did not exist. So one of the stipulations they had is that you cannot prepay for medical services. So well, that immediately knocks out the annual membership. Some people have contended, and it's up to every individual whether they wish to do this. I don't encourage anybody to wave a red flag in front of the IRS. But in theory, if you can't prepay for medical services, you could build a membership at the end of the month for the prior month's membership. So you're not prepaying. That's one of the theories on it. There is actually a bill that's working its way through committee, so God knows whether it'll ever get out in DC, that's trying to say that direct primary care does qualify. You can cover massage, you can cover dental service, you can cover all these other things in HSA. If you can pay for massage and acupuncture, why can't you pay for primary care services just through an innovative model? So that if that ever gets out of committee, I can't imagine it wouldn't be passed. But that would clear it up. So there's no ambiguity. You don't have to be fearful of doing it. But as of today, it is unclear whether HSAs or FSAs can be used for that purpose.
And I just want to clarify, directionally, this is something the federal government's supportive of. We've, Dr. Tom Price, who's the new Secretary of HHS, is one of the people we got together, and I was actually involved with the transition team to make that recommendation. He's an advocate of free market healthcare options like this. Dr. Seema Verma, she was the architect of the Healthy Indiana Plan, as many of you guys know, since we're pretty close to those guys right here. She's supportive of this as well. I've talked to her about direct primary care a few years back. President Trump in his budget this year put together a direct primary care Medicaid initiative. This is on their radar right now, so this is not a high-risk proposition. Chad's correct in that it is a little ambiguous right now. But the good news is the people that make the decisions around that ambiguity right now are favorable towards this right now. So with Obamacare, the actual HR 3590 is about 965 pages long. Not a great read, as I was talking about, but there's 20,000 pages of regulations associated with it. Those regulations are in control of whoever is in the executive branch at that point in time, and we've got very, very favorable winds in that regard right now.
Question about the practical aspects of the telecare. So I run a nonprofit that deals with people who have barriers to accessing healthcare in terms of finances, transportation, lots of other things. And so does the telecare, is that something that works 24 hours a day? Does it work during the day in office hours? And practically, how does that work? I have a lot of people who fit into the category of, I let it go, I let it go, I let it go. Now I really feel bad, so I go to the emergency room. So and so I'm looking for some way to provide opportunity for them to access more preventive care because it helps us, it helps them in all ways. So just practically speaking, because they very often also don't have access to computers, but we're going to have a computer lab in our facility where they may be able to sit down at a computer and say, for your example, I have this rash. How does that practically work?
So Rick, I'm going to answer that in a general sense. So for too long we've waited to not use any technology in healthcare. We're very antiquated with how we deliver care, and people have been texting for years and years now, and almost everybody has a cell phone. So one primary communication means we'll use will be texting. So I think you heard Chad mention that. So it may be a case, and I can't say that we've set up our schedule so that we have blocks of telemedicine visits, but I think a lot of it stems from the point of contact. So when a patient contacts us, texts us, hey, I really think we need to do a televisit. Sure, let's go ahead and set that up. How does half hour from now work for you? So again, I don't think we have those details worked out, but we have the mechanisms that will be in place, and people can text us. That's so easy then to springboard into a telemedicine visit. So does that answer your question?
Yeah. Okay.
I'd just like to add that we'll also have access for telemedicine on weekends and holidays, and evening hours as well.
Okay.
How's it gonna work? We have people scattered throughout the county. We have employees that are in Kentucky and Indiana who are salesmen who work, in their locations, but they use our insurance currently. But like, families in Buchanan or Dowagiac who, their kids go to school there, if they get sick during the day, are they gonna have to go pick them up and then bring them back to St. Joe? Can you kind of answer those questions?
Well, depending on the severity of the illness, sometimes it is necessary to come into the clinic. We'll have the doctors and our nurses available to triage that over the phone. If it's something that can be managed through telemedicine and that's convenient for everybody and safe, then that would work in our model. But if it's a concern that the kid or adult needs to come in, then that would be the case.
One thing that, Chad did a great job, but one thing that my slides had on there was just some details as far as our accessibility. So most primary care clinics are open from about 8 till 4, 8 till 5. Friday afternoon, they're gone. So our hours are going to be expanded. We've always had expanded hours. We work from 8 till 8, Monday through Thursday. Friday, we're open all day, 8 to 5. Somebody is almost always there on a Saturday morning, 8 till 12. And we're so committed to this that if somebody were to text us on a Saturday afternoon at 2 o'clock and say, hey, I just cut my finger out in the yard, can I just meet you at the office? It'll probably be a scenario where we'll probably say, hey, can you just take a picture of that? I just wanted to see what your laceration looks like. Yep, you need stitches. So instead of me sending the triamcinolone cream into Walgreens, I'll say, you know what, if you could just meet me at the office in 10 minutes, we'll put some stitches in there for you. And so that's the level of commitment we have to this. And I have some patients who have said to me, you're crazy. You're going to be spending the whole weekend at the office when you're on call. Well, probably not. But the reality is that we want to just be accessible to people. So we don't want to be checking out at 5 o'clock on Friday saying, be back on Monday, so you're on your own on the weekend. So access is a huge deal to us. And the beauty is that we have 4 docs, and we can spread the work around on those after hours and weekends, so we're not getting stressed out. So I think each of us can handle a weekend at a time. So.
And I want to address out of state. One of the recommendations from an employer perspective, Michigan's not the only state with direct primary care. I've been working with other state elected officials across the country. I think we've got the law that I passed here in Michigan, passed I think in 16 other states right now, including Tennessee and I think Kentucky has it as well. We're working with them on it. So one of the ways you could approach it from an employer perspective is provide them with a stipend equivalent to what everybody else is getting for their direct primary care and ask them to identify a physician in that area that they could work with, presuming they don't want to just have a wellness check when they come in once a year and pop back up here and then they do everything else telemedicine. I mean, that probably might not work out so well with them, but you could provide a stipend that's on par with some of the other employees and approach it that way. This is spreading. This is not, the reason I got plugged into this was I was actually watching Huckabee one night and they had Dr. Doug Munamaker is a partner of Dr. Josh Humbert. If you guys have watched Hannity at all, Dr. Josh is a regular on Hannity, and he's the first person I ever talked to about direct primary care. And this is not just local to Michigan. So I investigate to see whether or not, first of all, foremost, if you go to DPC Frontier, I think they've got a list of all the different states that are eligible on that. And I think you guys are, that'll give you a good indication of whether or not you got a footprint for this style of medicine somewhere else.
Excuse me, what was it? The Frontier, what was it?
DPCfrontier.org, I think it is, or .com.
And it's got a specific mapper. You can pick your state and it'll tell you your direct primary care physicians in that state.
Yeah, the sad truth is there's no one comprehensive site. So there's a lot of little mom and pop DPCs out there that aren't on it, but it's probably the best website for finding DPCs.
Yeah, it's actually managed by a gentleman who's a direct primary care doc and a lawyer. So he helps keep us all reined in on all
Yeah,
this.
yeah.
So Dr. Phil Eskew is a really good guy.
He's one of the ways that says, when they ask legal questions, say, you're not an attorney, you're not an attorney. It's not legal advice.
And also, I'd like to point out too, just because a state doesn't have the direct primary care law that we passed, doesn't mean that they don't have direct primary care docs in the state. It just means that they're running at risk, increased risk than what we're doing here in the state of Michigan, where the insurance authorities will come in and start, regulating their business practices. So it kind of perverts the DPC model, but most of the time they fly under the radar. But so check it out in some of the other states if you're outside of Michigan.
Also, now when you go, let's say you get a test done, there's the local places, you can go to their website and see your results. Your practice going to be, I think they've heard that before, that you were going to be putting those on.
Yeah, we have a current electronic health record system that we're using. We're going to be transitioning to one called Elation, where the patients can come in, they can look at their results, and they can see what they are. And send us messages that way. There's a lot of interactive potential with this. If you have a Fitbit, we can see how many steps you're walking if you want to sync it with us, so we can really keep you on track.
Even more.
So that's right. The whole purpose of the new system that we're getting is interaction and keeping patients involved in their care and communicating with us as easily as possible. So yeah, we can see it in there. Any other questions?
Yeah, another question I have is going back to my blood testing. Kind of the things in between. I go to a blood doctor once a year. I have ITP, so I have to get tested my platelets stay at a very low level, so I get tested every 3 months, depending on where they are. So would I wind up doing that in your office, or would I still go to that doctor? And what kind of insurance do we need to keep as a company?
So it depends on each individual and how many specialist visits you need to have. For those labs, you can certainly get those done through our office at our pricing. So you don't have to go and get your lab done at their office, which will then cost you whatever the standard pricing is. Just come here and we'll send the results to your specialist. It depends on a case-by-case basis, how much stuff we can manage, and then if something changes, if you have a stable condition that we feel comfortable managing, then certainly that's fine. But if it's something that's variable and you really need to be seeing your specialist, we would encourage you to continue to see them, which you would have to, either pay out of your insurance or, they would bill them in their standard kind of fee-for-service model.
And if I can add a point to the HSA is only questionable, if I can add to the HSA is only questionable for the membership. The meds and the labs and all those things that are done in the direct pay approach, there's no ambiguity. Those are attributable FSAs and HSAs.
And if I can add, my son, he's a specialist, and just with our family, with the price that we reduced our premium by, the amount we reduced our premium by, which was about $4,000 by switching to a higher deductible. Saw my son's specialist, and it was $300. And that would have gone out of our deductible anyway. That other did the even lower deductible. So it was cost effective that way.
Yeah, so here's a hypothetical. So you're doing your CPC every quarter. So they're honoring the CPC order from the specialist and probably forwarding those to them, right? That's what we do. And so now you got your $2 CPC and you're running it through your HSA. So it's $2 minus your tax rate. I mean, that's almost free. Almost.
In a couple of years, it'll be free.
You do. Any other questions?
Yeah. Thank you so much, everyone, for coming. We appreciate it. And if you have any questions, you're welcome to come up front.